Welcome everyone to the Buncke Clinic series of virtual visiting professorships. I am Bob Aksafa, and along with my partners Greg Buncke, Rudy Buntick, Andrew Watt, and Walter Lin, I'd like to welcome you all. This morning we are delighted to welcome a very dear friend, Professor Oskar Aszmann from the Medical University of Vienna. Let's see here. Sorry, let me just get my there we go. Good. Oskar is originally from Vienna and trained in plastic surgery in Vienna, but subsequent to that, he traveled to the US and completed a fellowship with Professor Lee Dellen, who obviously needs no introduction as a global thought leader in the field of peripheral nerve. And while in the US, he also spent a fair amount of time with Tom Brushart from Johns Hopkins doing a research fellowship. And so he spent many years post training in his plastic surgery, really specializing in the nuances of the peripheral nerve and also the science of it from a research standpoint. And he is now the director of the Center for Extremity Reconstruction and Rehabilitation at the Medical University of Vienna. Professor Aszmann has really become a worldwide expert in the field of not only extremity reconstruction in the upper extremity in particular, but also in the field of myoelectric prostheses, bionics, and using, and you'll see, using various techniques to maximize the use and function of prosthetics for upper extremity amputees. And he's won many awards for this, as you can see on the top right. So we're really looking forward to your talk, Oskar. On a personal level, I had some time to spend with Oskar at the German microsurgery meeting. You've seen many pictures of this meeting. We've had speakers who attended the Munich meeting, including Gunter Germann a few weeks ago, Professor Neumeister, Paul Sederna, obviously Oskar today, and Scott Levin. So this was a fantastic meeting, and it was a chance for a lot of us extremity surgeons to get together and share knowledge. With that, Oskar, thank you so much again for being with us. It's an honor to have you, and we're greatly looking forward to your talk.
Thank you. Let me ask you, how much time do I have?
You have actually a whole hour, and we can always go over if there are questions, so don't feel rushed at all.
So there's no pressing surgical schedule that is still ahead of you, or?
Not for me. I have a couple of hours, so I'm good. And it's being recorded, so if somebody has to run, they can always watch it later.
Okay.
So I have just made you a presenter. If you share your screen, we should be able to see your desktop.
Do you see it now?
Yep.
You see it? Okay.
And I will ask everyone to please keep your microphones and webcams off so that we don't have any distractions during the talk, and so we can.
Oba, can you tell me? I don't hear you. Do you hear me?
Yeah, I can hear you. We're looking at presenter mode. So if you go up to the display settings, you can swap presenter view and regular
just
view.
So I know you hear me, so then I'll start.
Oh yeah, we can hear you perfectly.
Okay, good. So hello everybody. Thank you, Bobak, for the introduction. I have basically spent my entire enthusiasm for the last 30 years on nerve reconstruction, and that has been my starting point. And from there, evidently, I jumped into the subject of extremity reconstruction or facial nerve reconstruction or any nerve found anywhere. And so this is a summary of a way that I've been traveling for the last few years. And so since about maybe 12 years, we started to explore the limits of reconstruction towards using mechatronics to restore extremity function as well, if we get to these limits. So this talk is basically trying to to define the line as to when we can use biological and when we can go to mechatronic modes of reconstruction.
Oskar, if I can interrupt for 1 second, I'm really sorry. We're viewing your presenter mode, so we actually are seeing two slides. If you can swap, on the top there's a display setting, the second option on the top left, and if you click on that, you can swap the presenter view. Then nope.
Right.
Let's see.
Big Jim.
It was the button just to the left of what you pushed, I think. If you can probably get out of presenter mode in PowerPoint and relaunch the presentation, then we'll go from there.
Okay, I'll try that. Hmm.
And I can also take presenter control back and give it back to you. That may give you another, let's see here. Okay, I'm gonna make you presenter again. All right, so you're gonna be made presenter again if you now share your screen again with us. Perfect. Now, in the top, you have three options. The second, in the middle option, yeah, that one, there should be a swap. If you press on that, swapping, yeah. Yep, that one.
Is that okay?
Perfect.
You got it?
Yep, that's fantastic. Thank you.
So, okay. Yeah, so, and this is a, so these are the, can I close this here? No, probably not.
Yeah, that you can minimize, and we actually can't see it. So it's only
Okay.
yours, and you can minimize it so it only hovers in the top corner.
Okay, so I can see everything. Okay,
yeah.
So these are the patients we see. So these are, so the top row would be brachial plexus injuries, then obviously congenital malformations of any kind, and or traumatic losses of extremity that can be due either to some massive trauma or maybe a sarcoma or some other tumor, so that patients need to have their parts of their extremity removed. So many, so how do I advance the slides now? Oh, here. So this is a slide I particularly like because it reveals that extremity reconstruction in the 21st century has many options. So to the left, do you see my cursor?
We can see your cursor, but someone has their mic on.
Yes.
There we go. I just turned it off, but we can see your cursor. Yep. Thank you.
Okay, so here you see these are the two hands of the oldest hand transplantee in the world. And so these are two transplanted hands. This is a homodigital transplantation from the other hand just before we had to amputate that one. So we had at least one hand with 5 fingers and the other one a bionic reconstruction. This is a unilateral hand transplantation, and these are some other bionic reconstructions. So I remember training with Professor Milesi many years ago. I thought some of the brachial plexus injuries that I've seen, they had maybe good shoulder or elbow function, but the hand was in a very bad state, and they were really not recoverable. And you will see that as part of this talk as to how to do that for these unfortunate group of patients. But I'll just walk you through some patients just to get the idea as to what we see and how we reconstruct these. So this would be a Ewing sarcoma of a 7-year-old boy, and he was referred to me with the question of whether we should just amputate the arm and then do a bionic reconstruction or do some other thing. And so this is the state. We see there is a bone cement to basically reconstruct the humerus. There is no biceps, just the soft tissue sleeve around, and so really not much we can do at that point. And so we have done a reconstruction of the humerus with the free fibula with the growth plate. This is the tendon of the thigh muscles, and for reconstruction of the supraspinatus, and then put that into a dead man's bone to reconstruct the humerus, which is this here is the growth plate. And then a few months later, we reconstructed the biceps with a bipolar pec major transfer, and at the same time a trapezius transfer to stabilize the shoulder. And here we see the video of him. Sorry, somebody has his mic on again. And here we have the boy grabbing this and showing off his biceps. And in the next slide, we see him pouring his glass. So this reconstruction, I think I just made that point, is to show that whatever we reconstruct, this is obviously the much better option than having any type of prosthetic arm for this in this scenario. And here we see him showing off his biceps with the bipolar pec transfer. So here's another patient with an extensive recurrent chondrosarcoma of the shoulder. And again, the question was whether we just do a thoracoscapular amputation or prosthetic reconstruction. And again, because it's a chondrosarcoma, never with a clear margins, so we just amputated the entire arm and we resected the part of the tumor, which is this, and then replanted the entire arm, because obviously if you do an amputation at this level, any type of prosthetic reconstruction is going to be really difficult. And also this patient has been the CEO of a large company, having the need to fly constantly, and putting off his prosthesis and putting it back on in the clearance of the airports is obviously difficult. And this is him about half a year later with good sensation of his hand and some marginal mobility of his shoulder and wrist. And obviously, I think this is the much better option than any type of prosthetic reconstruction we can provide for this man at this level. Now, obviously, if somebody loses the arm, we have no other options than a prosthetic reconstruction. The way we do this today is that we use the muscles in the region of the stump. So this would be the latissimus, for example, or the pec major muscle, as targets for the nerves that are sitting in the region of the stump, to reuse these muscles for signal donors to drive a prosthetic device. So this brings me to the main concept of bionic reconstruction, which is from Sterling Bunnell, that the hand actually starts in the brain. And here we see all the motor neurons of the ventral horn that basically drive the hand. And as complex the hand is, it wouldn't be anything worth if it were not for these motor neurons driving them. So we make use of these motor neurons to drive the prosthesis. So the question is, how do we get the motor neuron information from the spinal cord into the machine? And I think that has been basically the holy grail of prosthetic reconstruction throughout the last 20 years. And I think Todd Kuiken, with introducing TMR about 12 years ago, I think has given us a tool that avails much in that perspective. So here we see this has been a classic reconstruction after the Second World War. And that's what we want to get away from and create a biotechnological interface to extract intuitive and clear biosignals that will be able to govern the prosthetic device. So the way we do this, and I think probably many of you know that already, so we have the different source nerves that are obviously still available to us, even in a glenohumeral amputation, and we provide for each one of these another muscle available in the stump. So here, for example, the pec major muscle or the latissimus dorsi. And obviously, we expect some target functions that are being realized from the prosthesis at these levels. So here we see the scarred nerves. So this is the pec major, pec minor, and these are the data highway, the brachial plexus at the infraclavicular level. And this is a short video just showing the intactness of the pec major with the different branches, the clavicular, sternocostal, the abdominal portion of it. And here the pec minor muscle already dissected out with its small branch going into it from the C8 root. And so here we do our nerve transfers, and this is about 6 months later, and we see when I ask the patient to flex the elbow, to open the hand, to close the fingers, different parts of his shoulder regions are moving, and then we're picking up this EMG information and then drive the prosthesis with it. And so here we see him about maybe 6 months after surgery, and here this has been our first patient about 10 years ago. And here he's training prosthetic function. Obviously, he needs visual feedback. He needs to look at the prosthesis to get the proprioceptive support that he needs. And so from here we went to this. This is about maybe 1.5 years after the surgery. He already had some brain training to basically get an idea as to how this works. And here we see this motor matrix, very crude at that point. So this is about 10 years ago. We do a lot better than that today. And he can do pronation, supination, wrist extension, flexion, 2 different types of grip, which means precision precision grip and collateral grip. We see that here, and flexion of the shoulder. Now, obviously, this is not a take-home device; it's a laboratory arm, but just to see how we can do at this point in time with prosthetic reconstruction, and this basically went through the world with the BBC. This was back then a really cool thing to do. So this is a patient with a take-home arm. He is an Austrian. He lost his left arm and his left leg. And here we see him with the same techniques. We've provided a very good prosthetic reconstruction that he can use. He is a, what do you call it, a baker. He has a bakery, and so he can use this arm in daily life. And here we see him with bimanual dexterity, open, close, pronation, supination, all that with a very intuitive format. So this was glenohumeral. So we have different options for glenohumeral patients. Transhumeral, I think, is the most complicated patient group, and we'll see why in a moment. So here again, the patient comes to us from the orthopedic department with the question after a soft tissue sarcoma of the elbow, whether we should just do a short transhumeral amputation. I'm sorry. And you can imagine how difficult this will be if we do an amputation at that level. Prosthetic fitting will be extremely difficult at that level. So we have done a resection replantation, something we do on a regular basis. I've just done one about 3 weeks ago with the same on the same level. And here again, this is another patient with the same concept again, a resection reconstruction of the elbow. And here, if you look at him, it's a short arm. However, in the body image, it is not really apparent if he sits in a chair. And if you see him, for example, cutting his schnitzel, he can do that rather easily, and it's doing quite okay. Or here, pouring a glass of water. It's a fully sensate hand, and it's his own, so that means he kind of basically feels complete body image-wise, no phantom pain. So a much better option than any type of prosthetic reconstruction on a transhumeral level. Now, here we see a patient with a very short, this was a traumatic amputation. He is the owner of a company for earth movement, and his arm was amputated. And obviously, with conservative socket, you could never fit this arm in any type of classic prosthetic socket. And so here it's a 8 centimeter humerus that's left. We have put in an osseointegration with Richard Brannemark, and you see here the amount. I think this is really a phenomenal outcome. If you look at the range of motion still possible at this very difficult amputation level. Now, if you look closely, I don't really know where the deltoid inserts, but it must be somewhere there. But he still has unrestricted elevation at the shoulder joint. And it's a very simple prosthetic device. It's a body-powered device, but he's super happy with this one, and he can drive his gadgets, whatever he has with this earth moving business. So even though it's a very simple setup, I think it really helps the patients as much as he needs the arm, and it has full range of motion of the shoulder joint. And here we have 2 videos up. These are upside down. Sorry for that, but you can get the idea that it's a unrestricted motion. He is basically prosupination because of the fact that he can rotate the arm up and down. And so I think this is a great outcome for this level of amputation. Now, cubital, it's pretty much the same. This was a Ewing sarcoma. This is a little boy, 13 years old, from England, who was his father called me and asked. So they have proposed to do a transhumeral amputation again. And so again, we do the same concept with the resection replantation. And here we see the resection. We left the ulnar nerve intact because it was not touched by the tumor, and we've done a resection with all the other parts of it, with the replantation, obviously. And this is the boy about 3 months post-operatively, still the chemotherapy. And body image, I think, is phenomenal. I mean, if the nurses tell him, they tell him to bend the elbow, but he doesn't have none. So I think it's almost difficult to pick up for professionals that the elbow is missing. And so here we see this is very shortly, this is about 3 months after surgery, he can already extend the wrist. He has great sensation, obviously, in his little finger and some intrinsic mobility that you can see here. And this is another one here. This is a video his father sent to us about maybe a year ago, and you can see him climbing a wall. And I think this should be another video. Yeah, here. I think this, I just got that video about maybe 2 or 3 weeks ago, and his father was almost crying in the background. If you look at the amount of mobility, about the extent of function that the young man has here with his hand, you look at the smile on his face, I think there's no doubt to me that this is much, much, much better than any type of prosthetic reconstruction, especially on a glenohumeral, on a transhumeral level. And we'll talk about that in a moment as well. I think it's in that talk also. So transradial, so we just saw a 13-year-old boy. So this is a 70-year-old guy, again, with the fourth recurrence of a fibrosarcoma of the arm. And so, I mean, we can think 70 years old, he has not much time to live, but I think especially if it's the older population and maybe even a palliative setting, I think we must strive to do a biologic reconstruction as much as we can. So we've basically resected the entire functional tissues of the arm, including bone, reconstructed all with free tissue transfers. And this is about a year later with, I think, excellent hand function, both for the basic tasks, but also I think there's, yeah, so here we see also for minor tasks, I think it's an excellent reconstruction. I need to say that this patient eventually died about 5 years after this video has been done. However, I think he had an excellent quality of life in regards to hand function for sure, because of the reconstruction we have done to him. Now, obviously, if that's the case, there's really not much choices we have. So either we do a hand transplantation, and I have the strong conviction that this is the only indication for a hand transplantation today, or a bilateral prosthetic reconstruction. So this is the world's oldest bilateral hand transplantee. This was done in 2001. I know the patient personally, and you see a video of him in a moment. And I think I've seen about 20 patients with hand transplantations, and this is definitely the best one. And he's from Austria, and he's been done in Austria by Professor Pisa in 2001. And he's still doing excellent. He has one immunosuppressant, that's all he has, and he's doing phenomenal. Now here we have, this is a video about 4 years old. He has a 2-point discrimination of 8 millimeters in his index finger and thumb, and he has intrinsic mobility. And I think obviously this is much better than any prosthetic device can do. But again, I think the price we pay is worth paying for a bilateral hand loss. For unilateral, I think the price we have to pay is too high, and I would still resort to prosthetic reconstruction. So we have done, if you're interested to read more about this, we published this study in 2016 in PLOS ONE, and it's comparing the outcomes of a number of hand transplantation patients. So these are different cohorts of different centers in the world with prosthetic fittings. And basically the outcome, just to make it short, is that there's really no difference in regards to objective hand function measured with various outcome measures, except obviously the sensory lack that the prosthesis has, and with all that comes with that. So here I think comes the most fascinating part of my talk, and this is obviously the limits of a unilateral loss of function or amputation. So the patient groups we're looking at are tumor patients, trauma, Volkmann's contracture, ischemia, plexus lesions, and we'll see that in the very last part of my talk, also patients after a stroke. with irreversible loss of hand function, which I think is an extremely interesting patient group coming up for this type of reconstruction. So these are the hands that we see, and I could tell you stories of each one of these hands and how complex the pathologies are, but you can see these hands are wasted. It's a biologic wasteland. There's not a single nerve going in there. It's an asensate hand, and there's this, for example, we'll see them also in this talk. He has had an avulsion injury, so there's no vessels left for any type of complex reconstruction. And so what do we do with these? And I'm sure many of you who are listening to this talk now, that you have patients that are in this kind of situation, and you have wondered what you could provide for them, or do some other, whatever, wrist arthrodesis or finger transfer, I don't know what. And in the end, you still get an academic result where the patient has maybe some or minimal hand function, but not useful for any type of useful life that he lives. So here, this is my very first patient that bionic reconstruction ever kind of like came to my mind. And he has been an electrocuted patient where both hands were in trouble. So this is a groin flap, a free groin flap. This is an ALT flap that you can see here. And we have tried to introduce tendons to all the fingers with the fascia lata, nerve reconstructions to reanimate the hand. And it was really difficult to get this hand going because of all the collateral damage from the high voltage that went through his arm, or both of his arms. So before we took that hand off, we used one of his fingers to reconstruct the thumb on the other hand. You've seen the patient in one of the first slides I've shown in this talk. And so then the patient comes back to me and he says, "Doctor, what else can we do? I need another hand." So I said, okay, so we'll just go for this idea. So I basically proposed to him a bionic limb reconstruction as it is. And so it's basically it has to do with surgery, with interfacing, and with robotics that we basically pulled together. And the idea is that we create, I call it a manunculus. It's not the homunculus in the hand, but it's a manunculus. It's a hand in the arm. That's how we interface with the bionic hand. And the way we do this, obviously, is by introducing nerve signals and basically also allowing the patient to have some type of feedback. And this is the ventral and this is the dorsal root, just to exemplify that. And so this is a funny image. You may think it's a video from the avatar. So that's a dream, basically, that we have, is somehow to connect our neurons with any type of prosthetic device so that we can connect intuitively to the device. And that is what our big aim is in whatever we do in this regard. So this is a very unique slide. It is this is published in the Annals of Neurology about maybe 2 years ago, and we have sampled every single nerve from the brachial plexus, from C5 to H1, all the way down to the deep branch of the ulnar nerve, and all these multiple small biopsies from heart-beating organ donors in our university. And we have, and maybe you can see this here, this would be this root C7, and you see these yellow dots. These are the motor fibers, and these are the sensory fibers, the red ones. And so the outcome from that study was really phenomenal, and that was that there's about 350,000 axons coming out of these 5 roots, so 5, C6, C7, 8, T1, and only 10% are efferent, meaning going out, and 90% are afferent. So really that means that movement is a sensory phenomenon in the end. But it also meant to me that there's only about 7,000 spinal motor neurons that innervate the forearm and only 2,000 that innervate the hand. So then I thought, all right, so there's only 2,000 motor neurons governing hand function and 5,000 in the forearm, then theoretically it could be possible when we do targeted cognitive nerve transfers to display the entire range of motion in one muscle after a selective nerve transfer. So we've done an animal study where we have rerouted the ulnar nerve into the biceps, and then we looked at as to what type of nerve fibers are represented there. And the amount of nerve fibers that make functional connections. And this is we have published that in Science Advances just in January last year, and you can read it up if you want to. But the simple outcome is that really, if we take the ulnar nerve and we put it into a very stupid muscle, which is, for example, the biceps in this animal model, that the ulnar nerve is displaying this complex neuronal information in that muscle. So basically, this means if I take the ulnar nerve, which is responsible for playing the piano or playing the flute or doing surgery, whatever, we can use a very stupid muscle, the biceps, to display this complex information at that level. Now, obviously, it needs a very detailed hearing aid, an interface system, so we can listen to every single motor neuron talk. And this is where Dario Farina comes in, and we have published his work now in Nature Biomedical Engineering about 2 years ago, where we do exactly that. So we have a high-density EMG matrix pickup electrode sitting on the biceps muscle of the rat, and we can get this information out and basically get into every single neuronal activity that is being active during hand function. And after we've done our animal study, we have repeated that study in patients where we have done actual ulnar nerve transfers, for example, to the pec major or to the brachialis muscle, where we've done this exact same study with surface electrodes. And this is what was published in Nature Biomedical Engineering in 2017. And so the outcome of that study was that, in fact, we could decipher basically every single motor neuron, every single of these 7,000, and thus theoretically can control a very complex hand device. So here we see a patient. This is a student in our laboratory, and we have now 6 electrodes mounted around the forearm. And if you look at the prosthetic device, it does exactly what the patient tells it to do. And I think the interfacing is rather simple for this setup, and we see the, I think, excellent quality of hand function displayed here. Now, you just remember the patient that I've talked about with the electrocution injury, and I don't know how many surgeries he had. And I brought him into the laboratory, and I've shown him this hand function, and he said, "Doctor, why can't we just take this? This is doing a lot better than my own hand, and probably than it will ever will." So here he is. This is the same patient again. This video is about 10 years old now, or longer than that. And I wire him up. This is in our laboratory. This is a virtual hand. It's not a bionic hand as it is. And now you must remember this patient has not had hand function for a long time. And then he sees he can prone it. So that's him governing or controlling this virtual arm. And he was crying on that moment. He said, "Doctor, I can move my hand." I said, "Yes, you can. Your nerves are still there. It's we just need to translate that into prosthetic function, and you're going to be okay." So I have an ethical committee, and so we have done a symposium with different doctors, patients, ethics specialists, just to discuss whether it's okay that we can electively amputate an arm and replace it with a mechatronic device. And so at the end of all these discussions, we have passed all the IRB approvals, and then we have gone forward. Now, this is a very interesting slide because it exemplifies what we do. So this is the patient's hand again, replacing it with a mechatronic hand. And here I have the word MOT, which is for motors, because then I told him, all right, so if we come to the conclusion that your own hand will not work, so we might as well just make enough space to get the motors also installed. So there's no sense of making the amputation and having the arm too long, so we cannot make enough space for the mechatronic replacements that he needs. So that means I amputated the hand about 16 centimeters below the elbow to make enough space for the prosthetic device. So this is the horrible picture for any hand surgeon. So we amputate the hand and make space for a prosthetic reconstruction. And this is a video about 3 months. I mean, this is for any type of hand surgeon who knows 3 months is not a long time. So this is 3 months after amputation. And I think this is excellent hand function from any perspective. So then once that was done, I thought to myself, okay, so this was an electrocution injury. I know lots of patients who have had a brachial plexus injury like this one. If you look at the end of surgery, I always make small drawings. So this is in 2001. And so you can see here, it's a rupture of C5, 6, 7, and an avulsion of C8TH1. Now, anybody who knows anything about nerve or hand surgery will know that the hand will not go anywhere. So we reconstruct the plexus, and put a plate into the clavicle. This is 10 years later, I think. All right, so he can bend the elbow, he has shoulder stability, but the hand is absolutely useless. He cannot pick up this piece of wooden block. This is the rest of the patient. So we can already tell from here on, it's a biologic wasteland. There's nothing left except skin and bones. However, when I tapped him on his radial canal, he said, I have a Tinel-Hoffmann sign right there. So I thought, if you go back here, I have no idea which of these nerves made it down into the deep branch of the radial nerve. And so I said, okay, so let's try that. I mean, so we put him back into the operation room, to derotation osteotomy to get the arm out in space. We take a free gracilis muscle, and here we have the deep branch of the radial nerve, and stick it in here, make a free functional muscle transfer, not with the purpose to drive the fingers because they're beyond any type of functional restoration, but just to provide an EMG signal that can drive a prosthetic device. So we've done that, and then we waited, obviously, for regeneration to take place, and then I asked him to think of hand function. Now, how do you think of hand function if you don't have a hand? Not a hand that's working, at least, and we don't know which nerve fibers made it down through this reconstruction. So I've set him in front of the computer screen with an EMG, surface EMG on the forearm, and then I have him look at the screen. And about 9 months later, it really took a long time for these motor neurons to find their way. And if you look at this is a myoboid. It picks up EMG activity. He could activate hand function. He said, doctor, when I think of, I don't remember which function it was, then this EMG comes up. And he was really excited about that. And then we train with you've seen this video, but it's a very similar setup. It's another patient, but it just brings on the point. We do prosthetic training. Now, the way we do this for these type of patients, this is the same patient now. We put a third hand to the patient. It's a hybrid hand. So here we have the EMG signals driving the device. You remember he couldn't pick up the little wooden block before. Now with this add-on hybrid hand, he can pick up a baseball easily. Now, some patients are not convinced by the laboratory setting and they take this home. And here we see 1, 2, 3 hands, and he has a smile on his face. He is pushing. You see, it's full. It's not an empty barrel. He's pushing the barrel with his third hand. So for him, it needed that experience to realize this is a real good idea for him. So this is also a brachial plexus patients with a 3-root avulsion. So again, we amputate the useless hand and we do prosthetic reconstruction. And this is again exemplifying the amount of function we can get out of these patients. Now, so he's opening, closing. It's a precision grip. And if you look at these patients and you talk to them, this almost goes second nature after a few months having a prosthesis like that. Or here picking grapes. Now, obviously, this is not so easy for patients to learn because they don't have any haptic feedback. However, the motors, they hum and they give some feedback because they vibrate and they make a noise. And so the patient gets an idea as to how hard he grips and how much force he needs to apply to get the grape off there. So this is a patient that has had an avulsion injury. Again, I think anybody knowing, so looking at this type of hand knows already this is not going to go anywhere. So we have done all we can, skin grafted him. I think it was a larger, so we put the hand into the abdominal wall for a while to get a resurfacing of the skin and bones there. There's no vessels left, so for any type of larger soft tissue transfer. This is the motion he can do after 2 years. Now, he has been 24 years when it happened, and he and his brother, they are tilers, so they have a little shop for tiling floors. Now, you can imagine he cannot use that hand for anything. Plus, he had ulcerating wounds here because the skin was breaking down. And again, a little small Carroll test, picking up a wooden block. Now, it's impossible. Now, can you imagine him trying to tile a floor? So he has an ulcerating wound here with a bare bone of the olecranon, which also limited range of motion of the elbow. So it took me a while to talk to the patient and basically not convince him, but to present the options of a bionic reconstruction. And so again, we have done the hybrid hand testing, and here we see him not picking up a wooden, it's a full glass of water here. And easily he can, this is about 10 kilograms of force, so it's a rather strong hand. Or here pouring a glass of water. See, at this point, he already ulcerates at the thumb and index finger again. So this definitely is a very unstable situation as it is. So again, we have done a transmetacarpal amputation to preserve the wrist, and also do a free latissimus dorsiflap to cover the elbow to restore range of motion at the elbow. Do a C-plasty here at the cubital fossa, so he can full extension, full flexion of the arm again. And this is the video his girlfriend sent to us because he just didn't have any more time to go back to the hospital. He says, "Doctor, I'm doing fine. I'm working hard. I love my life as it is." And this is one, and there's another one tiling the floor. Now, and that's really true. Even though the patient only lives about half an hour away from Vienna, I see him maybe once in 2 years if there is any type of follow-up. But other than that, he's just gone and away and very happy working. So this is, for me, another proof that this really is an excellent way to restore hand function. I think I can almost skip that video. This has been a televised company asking him whether he feels as being a cyborg. And he says, "Look, I mean, I'm putting off that hand. I put it on in the morning. I go to work with it. I do my thing. And then in the evening, I take it off. And it's part of me like my shoes. And I definitely am not a cyborg." So just to say that patients, even though this is plastic and not flesh and blood, these patients are not, they don't feel weird about that. So if I still have time, I would like to talk about the last most exciting part. As of now, this is a new research project for us. And I think it's really exciting because this entails a lot of patients that we see here. So treating the neurologically impaired spinal cord injury, brain stroke. So I'm sure, I don't know if you see this type of patients, normally these are referred to other centers than the classic hand surgery unit. However, in the last few years, we have seen more frequently these type of patients. And I don't know if you have read that paper, just last year in May, it was published by Natasha van Zyl in Sydney. It's selective nerve transfers in tetraplegia. And I think this is a really fascinating group of patients that we need to also look at more carefully. So here, for example, we have a tetraplegic patient, and I don't want to spend too much time on this patient here, but so we have done our classic tendon transfers. You all know these. I don't need to talk to you about them. So this is the outcome. So he has great flexion. He's very happy with that outcome. He can pick up small objects, larger objects, things that he couldn't do before. And we have also done surgery on his left hand as well, I think, after that video. And so he's been very excited about this outcome as it is. We're here picking up a pen. So I think it's a worthwhile thing to focus on these type of patients because they really suffer loss of hand function to a great extent. And I think for many of these, we can improve them with just standards of hand surgery. Now with brain stroke, it's the same thing. And you may not have, maybe this publication passed by, but this was published in the New England Journal of Medicine in May 2018. And it's a very unique concept. So they have done a C7 nerve transfer from the contralateral to the affected side. And if you read the paper carefully, you realize that not only spasticity has come down dramatically, but also actual hand function has improved. That's not something that they particularly studied. And we wrote a letter to the editor about that because this is basically what we're looking for. But it's just to bring to the attention of us, I think, that even in spastic patients after brain stroke with cognitive nerve transfers, we can do a lot. So this is just, so here I'll just spend a few words on a few patients here. So selective cognitive nerve transfers and hemispasticity. So here's a patient that has basically no elbow function. She cannot use her elbow at all. It's a spastic muscle. So this is a paper we published many years ago. It's on medial pectoral nerve transfer to musculocutaneous for brachial plexus lesions. But cognitively, she can address the pec major muscle. So that means the second motor neuron is still attached to the first motor neuron for this particular group of motor neurons, but not present for the musculocutaneous. So obviously this is not a time-dependent operation because it's a spastic muscle. We can reinnervate that muscle anytime, even 10 years after the stroke. So that's what we've done. So here again, we see the medial pectoral nerve. So this is lateral, this is the shoulder, this is medial, and here's the musculocutaneous. And so we've done a rerouting of the musculocutaneous to the biceps. Now this is about 9 months after surgery. And look at that. I mean, I think this is phenomenal. She can flex her elbow cognitively. She can extend it, and she can use her fingers. So we have restored global hand-arm function. Now, for most of the spastic patients, it's not the elbow that's the problem, but it's the spastic hand per se. So this was my very first patient about a year ago, and so this is his video. This is what he can do with his right arm. I tell him, so it's a spastic hand. He cannot pick up that piece. You see, it's just impossible. Also, he has an internal shoulder rotation contracture. He cannot rotate the arm outward, and he has no hand function whatsoever. So here again, we have done the same concept. We have taken parts of the triceps to the extensors of the forearm, and we have taken part of the pec major to the pronator teres with a graft, with a sural nerve graft. So here again, we see the triceps muscle activating at that level, and we can do the nerve transfer to the extensor muscles also right up here. And we see here the spastic extensors, and the same with the pec major muscle, the lower pec, the medial pec, to the musculocutaneous. So we've done that to this particular patient. We've done hybrid hand testing, the same concept as you've seen before, the replacement of the hand. Here, an elective amputation about 9 months after surgery. Now look at the video here. So here we have the EMG pickups. He can flex the elbow. It's a lovely movie, I think. He can flex the elbow, extend the elbow. And remember, he now has EMG signals that he can cognitively govern because he has now pec major to the pronator and triceps branches to the extensors. So this is again him here flexing, extending the elbow, and this is a video of prosthetic hand function as it is. Now you remember the video from before where he had trouble even holding the jar. He can pick up clothespin. So I think this demonstrates the possibilities that we have in our time for patients with any type of big defect of either the first or the second motor neuron, and restore that with, I think, a high quality of hand function. Yes, it's not their own flesh and blood, but it's nonetheless, I think, an excellent quality of hand function restored. I think this is basically the end of my time. The algorithm of bionic reconstruction is complex. It's not easy. It's a detailed clinical assessment. Then we need a phase where we restore what we can restore, either through nerve transfers, free functional muscle transplantation, derotation osteotomies, whatever is necessary. Then we do a tech neuro rehab, meaning that we are doing cognitive training of the brain, motor imagery, and signal training. And then we do hybrid hand fitting, hybrid hand training, whatever is needed in regards to amputation, if that's needed, and then obviously prosthetic fitting. So this process can take a year, this process can take 2 years, but I think for most of the patients that you've seen today, I think the effort has been more than worthwhile. With that, I thank you for your attention. If you have any questions, I think Bobak, you can do that.
Well, Oskar, thank you so much for a fantastic talk, and this is exactly the kind of talk that we
I don't hear you. I hope you heard me.
I can hear you. Are you on mute potentially? Can everybody else hear me?
Oh, do I hear you now?
I think, yeah. Can you hear me? Okay, good.
Yeah,
Perfect.
I hear you.
Great.
Okay.
Yeah, I just wanted to say thank you so much for a fantastic talk. This is exactly the kind of talk that we would, we want to hear and we want to include in our library. So thank you so much for that. I have a couple of comments and then some questions as well. Obviously, as you showed, we're all reconstructive surgeons, and so our goal primarily is to try to fix the patients who come in, no matter how bad their injury is. But I think what you've shown is that no matter how good we are or we think we are, there's always a limit. And there are some injuries that are just simply bad enough that no matter what you do, the function of the hand is going to be somewhat limited. And I think this is where the work that you have done and some other folks around the world have done is really important, because once we reach the limit of reconstruction, then we see that we do have additional options to try to give our patients some function. The first question that I have is more at a high level. You've shown some fantastic results with prosthetic control. At a high level, what do you look for in a patient to see if he or she is a good candidate for a somewhat time-consuming and expensive process? Are there alarms that potentially will be set off with certain features, certain aspects? What do you look for in a patient for that?
All right, so I think there is obviously some requirements that he needs to bring neurophysiologically. So obviously, if the patient does have a loss of pectoral nerve function or latissimus dorsi or some other muscles that are the classic targets, we're talking about glenohumeral amputations, I suppose. You said high-level amputations.
No, at a high level, I meant conceptually. So just from yeah. So what do you look for in a patient? Yeah.
Yeah. So if all the neurophysiological and biological aspects are cleared and the patient is a candidate from his anatomical point of view, I think the most important is obviously compliancy of the patient. So meaning that he really wants to have a hand function. So there's no sense of trying to convince a patient that this is a good thing just because it's fancy and it's sexy. So the patient needs to say, doctor, I hate having one hand. I need another hand. Please do anything that I can have another hand. And obviously, we need to take care, obviously, that the resources both within the family, within the patient's psychological framework, the environment the patient lives in, and obviously also the financial support is there to pull that through to the end. As I said before, it's a lengthy process. It's not something that that is done like some other surgeries that we do, like a trigger finger, the patient comes and goes, but it's something that binds us with the patient for at least 2 years of our professional lives. So I think we need to make sure, so in our team, we have a psychologist, and she will spend time with the patient and talk to him and realize how the coping mechanisms are with the how he cope with the loss of the extremity if it's an amputation. And so I think that is very important even in the first meeting that you have with the patient, to touch on each one of these subjects, meaning that are there personal resources, how is the environment, how is the family, how is the financial support, so you will be able to pull it through to the end.
Great. No, that's great. I think is one of the biggest I think with any complex surgery or procedure like this, I think patient selection is always critical. So thank you for that clarification. I wanted to ask a question to get your opinion on targeted muscle reinnervation, some of which you've shown, versus the concept of RPNI, or regenerative peripheral nerve interface. We had Paul Soderna on a few weeks ago, and he showed his results with that. Please turn your microphones off if you're not speaking. Thanks so much. He has obviously his opinions about the superiority of RPNI over TMR. But we've seen good results with both. And so I just kind of wanted to pick your brain about what your thoughts are there. And also if you have any thoughts on how the body deals with the size mismatch of a large nerve going into a relatively small nerve. Thank you.
It's a very good question. Thank you, Bobak. So in regards to outcome, so as you know, today in the United States, the largest indication for TMR or RPNI is not really with the purpose of having it as a control signal for a prosthetic device, but it's pain patients. So I'm sure you're aware of Greg Domanian's paper in Annals of Surgery about 2 years ago.
Yeah.
That brought an entire new aspect on the subject of TMR, dealing with phantom pain or neuroma pain at the patient's amputation stump. And I think, obviously, so that's the slogan, give your nerve a home, or give it somewhere to grow, as Greg Domanian says. So I think it's very important, and in that perspective, I think there's not really a huge difference whether you use a TMR or an RPNI. However, I need to say that we have just published a paper, Lee Dellen and I, in microsurgery about 3 weeks ago, and it's called In Musculus Veritas. So like Veritas, so it's in. So the question as to what do we do, or what do we offer a nerve that has lost its target? And as you know, about 20 years ago, Susan McKinnon and Lee Dellen have published a paper on putting the nerve in muscle. So it's notably to say that it's a non-denervated muscle. So it's just, and that's I think what we all do as hand surgeons, we take a nerve and we put it into a live muscle nearby. And I think probably for 90% of our patients, this is probably a very good thing to do. And so now we have the options of doing a TMR or an RPNI. And I think providing a nerve alive, physiologically intact, very well vascularized end organ muscle is probably the better option than using small devascularized target muscles of small sizes. And so I'm just talking about neuroma pain treatment. I'm not talking about controlling a prosthetic device. Now, in regards to driving a prosthetic device, again, I think the problem is, so let's just say you have the median nerve on a forearm amputated patient, and you splice the median nerve into 6 different small fascicular groups, and then put RPNIs around. Now, the problem is that fascicular arrangement is not the same as functional arrangement. We all know that we have intrafascicular plexus formations, and we have no idea where the motor fibers of the flexor pollicis longus are in the median nerve in a proximal forearm. We just don't know. So the idea to have particular RPNIs with a particular or very specific EMG signal that is just elicited by the patient thinking of FPL function is not going to work out. And I think we all know that, because the fascicular arrangement and the topography of the peripheral nerve doesn't give us that freedom to say that this is the fascicle where the FPL and this is the pronator quadratus, and I don't know who else is placed. So that's why I believe that TMR is the better option, because yes, it's problematic. Let's just say you take the radial nerve into the thoracodorsal muscle, thoracodorsal nerve, So then I have a polytopic innervation, and the radial nerve displays, let's just say, supinator function, finger extension, wrist extension, blah, 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 all this at a large muscle. And the problem is that it's polytopic. It's showing up anywhere on that muscle. And the difficulty is to define a hotspot that will define the place where the prosthetic guy will put his electrode to govern a wrist finger extension. And I think so we need to work on that end to prioritize the interface. So Dario Farina, with his high density EMG matrix electrodes, he can do that. He can decipher the neuronal language at that level from a large muscle with a polytopic reinnervation. And I think we will do a lot better deciphering this information on a large muscle that speaks a fuzzy language, if you will, than doing fascicular dissections and then providing small pieces of muscle that may give you some dinky small EMG signal that for sure will not be able to be picked up with a transcutaneous electrode. So with an RPNI, you need to go in invasive, meaning that for your pickup electrodes, you need to have some implantable device to pick up that faint EMG signal, which I think we will go anywhere in the future. And Paul Soderna, he knows that, and we're all looking to get good companies to provide implantable technology to get to improve our hearing aid to listen to muscle activity. So, but in short, with all that I've said, and maybe you can read that paper in Microsurgery that was just published about 3 or 4 weeks ago. I think that the TMR is an excellent option for any large type of amputation where you have neuroma pain to do nerve transfers on a large scale. And for RPNIs on the forearm, for example, I would still rather do let's just say a free functional muscle transfer like you have seen now for this one of these patients to provide a large healthy muscle as a target. Now, the problem that you have addressed with size mismatch, yes, that's problematic, obviously, because you have a large diameter nerve like the median nerve going into a very small dinky motor branch of any type of muscle. But what happens is that the majority still will make some type of functional connections. There will be a neuroma or neuromatous formations at the coaptation site, which we have at any type of nerve coaptation anyway. And yes, some patients will suffer. Will suffer from neuroma pain at the coaptation site because some of these nerves will not make functional connections. That's correct.
Right.
So that's my answer.
Well, thank you so much for your thoughts on that. That's great to hear. We do have Dr. Greg Buncke on the webinar. Greg, are you around? I think you have a question.
Yeah. Oskar, thank you so much. Appreciate your talk. It's wonderful hearing people as creative as you coming up with these wonderful ideas that are really so important for these patients. As you know, we're very aggressive about replantation of extremities, and you guys are actually even more aggressive than we are sometimes, and yet you have such great knowledge of what the potentials are, and you're on the forefront of what type of prosthesis are available for the upper extremity. Yet you also are now amputating hands that are not as functional and working with prosthesis. Has your algorithm changed over time now to tell us what sort of hands are replantable, and would you necessarily, are you doing something differently with emergency patients now?
Yeah, that's an excellent question. Thanks, Greg. So you remember in my talk, there was one guy with the avulsion injury where the entire soft tissue sleeve basically came out. It was the Tyler, you remember?
Yes.
And I was on call that night. That was about 3 or 4 years ago, or even longer than that. And I talked to his brother when he was just rolling into the emergency room, who was accompanying him. And I said to him, you know what? I think this hand is not going to go anywhere, and I would just take it off. I would amputate it as it is to save the young man years in the hospital that are lost in the end. And his brother told me, you know what? I trust your judgment. However, I also know my brother, and I think he just needs to say goodbye himself. and it's not a decision that is I am to make, and I think he needs to make it himself. So I took that to heart, and you've seen the outcome. It was 2 years of investment, and we really tried our best to get whatever we could save from the hand that was left. And so it was a skin grafted finger, and you saw the ulcerations. It was an asensate hand because all the nerves were avulsed as well. And God, I mean, after 2 years, and you know what that means, 24 years. I mean, that's the age where we all do our studies. We are having our relationships, and we basically format our lives as we want to have them. And these are very crucial and important years in our development. And so I think it's almost a crime to take away these precious years and basically bind them to the hospital and say you need to come back every 2 weeks for wound care and I don't know what. And so so just to say that it was on my mind, I proposed it to the family or to his brother, because obviously his brother was in shock, so I couldn't really discuss much with him. And but it was on my mind already to do an amputation right there and provide him a solid reconstruction that I knew would work. And so hindsight, I did it, and I think it was good in that respect because the patient really could evaluate that and could say goodbye to his own hand, and he knew we have tried everything we could do. And psychologically, obviously, this was good. But hindsight, I would still say that he lost 2 years in the hospital, and he could have gone on with his life much less traumatized psychologically. In regards to brachial plexus patient, I think this is a much different way. So let's just say, so we do brachial plexus every week. We see difficult plexus patients. So let's just say I have a patient come in with a C7, C8, TH1, so lower root avulsion, panplexopathy. Now, many years ago, I would have done whatever I could to also address distal targets. Now, with what you've seen today and with my experience today, I will not do that any longer. I will target all my nerve resources to reanimate elbow shoulder function and just get whatever is necessary to get into the forearm to get the most minimal amount of myoactivity. I'm just talking about not even function, just myoactivity into the forearm, because I know in the end the hand will not go anywhere. Now, it's not just my own personal experience. So I've trained with Manu Milesi, and I've seen all his patients throughout my medical training. And God, how many patients? I'm sure you do brachial plexus surgery at Buncke? I don't know.
Sometimes.
So there's many patients who have dismal, I mean, really nothing, no hand function whatsoever. But we keep telling them, come back, it's going to get better. But we know it's not going to get better because if a lower root avulsion is there, it's not going to go anywhere. So that's what changed my practice for sure. Today, I will not focus in these scenarios. I'm talking about panplexopathy with lower root avulsions, because I know it's an academic result. The patient may wiggle his fingers, but he can never grab a Coke. And so that definitely has changed my consideration. I may not say that to the patient up front, but he will realize with time, after 1 or 2 years, yes, elbow, shoulder comes back, is doing okay, but the hand is not going to go anywhere. And that's the point where I will present to him another patient who has had the procedure. Just by coincidence, they will meet in the hallway, being scheduled for an appointment, and he will say, "Oh," and they will see the bionic hand, and he will say, "That's I would like to have something like that." So they are being convinced not by my own words, but by the testimony of the patients who have had that. Mm-hmm. And so that has definitely changed my approach to that. And now with the stroke patients, I mean, I think this is going to be another bomb in hand surgery when we were able to reconstruct. You've seen the videos. I mean, that I think this is just unbelievable that we can restore hand function to patients who have just these clawed, spastic hands that they can have no function with. And so I think extremity reconstruction in the times we're living now, this is definitely going to be another addendum or another chapter in hand surgery.
Yeah, thank you.
Yeah, yes, thanks so much for that. I think, Oskar, it's just as challenging for the surgeon, I think, to go down the path of cutting off a hand or an arm as it is for the patient in some ways, because there's a concept of sunk cost, and I think from a psychological standpoint, you've spent all this effort and time and obviously the system's money on this reconstruction, and it's easy to want to pour, as we say, good money, after bad. But I think what you've shown is that at some point it's really good to take a kind of more high-level global picture of the assessment and see if the patient's better off with a really well-made prosthesis that they can control. I think your idea of using the third hand to get the patient accustomed to it and show that they can use it, I think it's a brilliant idea. And I think it's because it takes a lot of courage to cut a hand off.
Yes.
And I think that is a really good idea, and I want to commend you on that. We've had a few comments in the comment section that they really appreciated the idea of getting the patient used to having that third hand to make sure that everyone is on board. Now, one of the videos that you showed was really impressive, was the guy with the prosthetic hand being able to pick off individual grapes. And then you mentioned that, of course, he doesn't have haptic feedback. Is there any work being done on haptic feedback of these prosthetics? And if so, where are you on that?
Yeah, maybe just also a comment of what you have just touched on is the psychology of the patient. I can assure you that many patients come to me and they come with the explicit wish to have their hand taken off because they suffer either because it's asensate, so it's always in their way. It's being burned, as you know. There's many patients who have an asensate hand, and it's they just get in harm's way wherever they are. And so, really, at that point, they don't need much conversation about convicting them. This is a good idea. They come with the explicit wish and say, you know what, I'm so sick of my hand, it needs to come away. Body image wise, I think they have closed the chapter that this is ever going to be useful for them any longer. And even though they have the immediate loss at the moment of amputation, but I mean, they have seen videos from our patients before, so they know what's coming at the long run, so they get good function. Now, what was your question? The haptic sensation. So we have embarked on a research project just very recently to restore sensation. As we know, this is very important. Now, there is a big problem with sensation because if you think the fingertip has more than 1 million mechanoreceptors sitting at 1 square centimeter of skin. And it's not just restoring touch, because if you think of touch, it's a spatial distribution of mechanosensors and to distinguish between roughness and smoothness. It's the sequential stimulation of Pacinian corpuscles, Merkel's disc, what have you, to get that image in your brain that there is something, what we call stereognosis, that we can distinguish between a round or an edgy object. So it's not just putting a mechanoreceptor into a prosthetic finger, because that will basically just restore simple touch, meaning I'm touching an object and maybe a pressure sensation. But so we need to think of a larger image of what we're restoring. The second thing is time. Now, from the time a fly sits on your finger until you realize that the fly sits on your finger, it's about 30 milliseconds. It's a very small amount of time. Now, if you have a mechanoreceptor picking up any type of sensation, translating that into any type of language with any type of device that basically stimulates your nerve, and then the nerve getting that back to your brain, we are in about 150 milliseconds or more. It's way too late. It's old information. It's of no use to us. And we know that from many psychological evaluations. So it's late information, and it's like when you put your foot on the pedal to brake the braking pedal, and it's always there's a delay. You would hate that. Yeah. So it needs to be immediate. So what we are proposing, I called it the manunculus. Maybe you remember, it's a hand in the. So I call it a biohub or a bioscreen. So what we're now doing, we're transplanting glabrous skin to the muscle, and then are trying to simulate a movement. Now, I don't know if you, I'm just trying to remember the name, Eric Moberg. I don't know if you remember Eric Moberg. So Eric Moberg, he published a paper in 1986 in Brain, and he has done a very simple study. He has blocked the median nerve, and he asked the patient to PIP flexion of the finger. Now, PIP flexion is extrinsic flexion, as you know. Yep. But if the sensation around the PIP joint is numb, the patient has no idea in regards to proprioceptive ability as to know where the finger is. So we know that the skin envelope around any joint tells us a detailed proprioceptive feedback. So then the idea is we take a piece of glabrous skin, transplant it onto a muscle within an amputation stump, and then this transplanted piece of skin will be stimulated through an external device, and then this will simulate a movement. Make sense what I'm saying? Mm-hmm. So that is, first of all, it's rich information, and also it's immediate information. It's very quick. It's using its own biological system. So we have 2 animal studies going on right now that we are working up, and it's very exciting. First of all, that if you do a selective nerve transfer on a transhumeral amputation site, let's just say, and you put the median nerve or the ulnar nerve into the biceps muscle, and you transplant a piece of skin on top of it, then the sensory fibers will make functional connections into that transplanted piece of skin. And we're not just doing our psychophysical workup, meaning that that piece of skin also relays information back to the brain, so the patient gets some idea of a piece of amputated surface. Mm-hmm. And I think this is really exciting because it's a simple, it's not difficult, it's a simple device, it's a simple concept, and it doesn't need much or sophisticated proprioceptive receptors in a prosthetic device, which is, as I just said, it's really difficult to do.
Yeah, great. Thank you so much for those kind of future directions. Oskar, I want to thank you again for taking time out of your busy schedule to show us the incredible work that you're doing, and we look forward to seeing you hopefully in person soon. I know the ASSH was made virtual, but I hope to be able to see you in person over the next year or so. Sure. I also want to congratulate you on your recent publication in the New England Journal of Medicine. I think it's not very common for a plastic reconstructive surgeon or any kind of surgeon to publish in the New England Journal. So congratulations on that. I think it's obviously.
Thank you, Bob. I also want to take the chance to congratulate you. I said it to you before. I looked at the roster of speakers you had in the last few weeks. It's just a great idea, and congratulations to your team and your people at the Buncke Clinic.
Great, thank you so much. And on that note, just housekeeping items. I think I want to thank everyone for joining us from all over the world today. And tomorrow, Tuesday, at least Pacific time at 5 p.m., we have Professor Scott Levin speaking on the arrival of orthoplastic surgery, 3 decades of preparation. So we look forward to having as many of you on that webinar as well. Oskar, thanks again.
Thank you.
Say hi to everyone in Vienna for me, all of our friends there, and we'll hope to see you soon. Thank you so much.
Bye-bye.
Bye-bye.